our first speaker. I hope I say your name right. I was going to ask you before. Where is he?
I'm in front of.
I thought so, and then you looked at me a little crazy, and I went,
No.
no.
People usually
So, Dr.
pronounce. I can
Morkous.
pronounce it myself.
Morkous?
Yeah, Morkous, I guess. People
Okay.
say Marcos, but it's Morkous.
Morkous.
Yeah.
Okay.
And it's fine if you don't pronounce it right also. You can say Sam, that's okay with me.
Sam?
Yeah.
Okay. Dr. Sam Morkous. Dr. Morkous is the Chief of Pediatric Neurology at the Epilepsy Center of Lehigh Valley Health Network. He completed his medical school training at the University of Alexandria Medical School. His residency and fellowship in sleep medicine at Western Reserve Care System, and his 3 fellowships in child neurology at the University of Pittsburgh Medical Center. Dr. Morkous is board certified in pediatric neurology, epilepsy, and sleep medicine. He's committed to educating patients, families, students, and other doctors about epilepsy, as evidenced by his various speaking and educational activities. Please join me in welcoming Dr. Morkous. I'll turn this off. So, yep. Let's just do it there. Yep.
Oh, okay. Okay. So thank you everyone for being here. I see a lot of familiar and unfamiliar faces, and some of my patients, actually, families are here. So it's always nice to meet people, and I think that's why we all do medicine, because in this state of investigations and tests and legal worries, people forget what is medicine about. It's about taking care of patients and taking care of each other. And as we learn from as we deal with patients and they learn from us, we actually learn from our patients also. So thank you everyone for being here, and thanks for the Epilepsy Foundation and the sponsors. So we are going to talk about intractable epilepsy today, and I hope we can deliver some clear messages that can hopefully help people living with this disease to understand more about it. I am from Lehigh Valley, and some slides here. This presentation, I put it on the website for Lehigh Valley. It's available so people can go there and look at it after that if they want to. This is just a slide here about the quality metrics in Lehigh Valley. We try to stress on that. So the objectives of this talk today will be to define uncontrolled, or what we call refractory seizures. We're going to try to summarize possible causes of uncontrolled seizures. We're going to try to differentiate epilepsy versus epileptic syndromes. We're going to speak about epilepsy general classification and mimics, and also describe epilepsy investigation and treatment. So when I tell my patients that epilepsy is not a benign disease, but what I tell them more importantly, that epilepsy is not a diagnosis. So when people say epilepsy, and they come and tell me, oh, my kid is epileptic, or my adult member was epileptic, we need to understand what kind of epilepsy is really what we are trying to define as physicians, because this can guide management and choice of medications. And epilepsy is among the most common serious neurological conditions, affecting 1 in 26 people, as we just heard. We have no geographic, social, or racial boundaries. Anyone can get it, right? So we're all in this together, and it affects people of all ages. It can be associated with comorbidities, and what is more important than the epilepsy itself is what it means to us as people, how it's affecting our daily life. And you know, we have some great examples here about people who have been fighting this. I've been talking with one of them earlier, and how this can affect your life, either having the disease or being treated and potentially cured from the disease. So this slide here, I just want to show people, in general, seizures have a lot of causes. Some of them are structural, like in the brain. Some of them are, sometimes it's not obvious, as we just heard also. But you can think about it as a chemical problem also. So what happened is, this is the wiring of the brain. This here chemicals, they're called neurotransmitters. And it's basically an imbalance between transmitters that keep your brain down and suppress it, and transmitters that excite your brain. When you have more excitation than depression, then you can get a seizure from that. So what do we mean by uncontrolled or refractory seizures? Seizures are not controlled when basically we use medications and it's not working. technically speaking, 2 medications or more. We can call it uncontrolled, intractable, refractory, or drug-resistant. And data suggests that 1/3 of cases with epilepsy or seizures might not be controlled, unfortunately. Epilepsy specialists strive for patients to have no seizures, and that's our goal. But sometimes that's not a realistic goal, so we try for the best possible control that comes, or we can get. So one of our respectable organization, International League Against Epilepsy, they set the guidelines and evidence-based guidelines that we try to follow. Define drug-resistant epilepsy, we can say DRE. They use this term when you have failed to become and or remain seizure-free with adequate trials of 2 seizure medications. Now, the point here is that it has to be the right medications also. So not any failure is a failure. You have to choose the right medicine, and you have to use it for adequate amount of time before saying it's failed. So there are certain criteria for that. And also, you use the medicine if there is a side effect and you have to switch to another medicine. That's not technically a failure. You don't count that in those 2 seizure medications. And seizure medication have been chosen appropriately for the person's seizure type and well tolerated by the person. That's why it's important to understand what I have. So when people come and tell me I'm epileptic, you need to ask your neurologist, what do you mean by that? Where are my seizures coming from? What kind of epilepsy syndrome I fit? If there is a diagnosis, you can give me more specific than just tell me I'm epileptic or I have seizures. And the Epilepsy Foundation has a lot of resources that can guide you about different epilepsy syndromes, because what to treat and how long to treat and what medication to use can depend on the type or the title that you will give to this medical condition you have. Now, what are the possible causes of uncontrolled? So we hear this a lot. What is causing my seizures? And seizure in general can be uncontrolled for a number of reasons. You might have the wrong diagnosis, and that's important. So there are some mimics we are going to talk about briefly that can mimic seizures. So that's also part of the diagnosis, is to make sure do you have the right diagnosis, not being labeled with being epileptic or having seizures when you have something else. A lot of times people do that, and I see that. Even some neurologists sometimes, they have an abnormal EEG and they jump to the conclusion that that person might have epilepsy or seizures. As I always tell patients, we don't treat EEGs, we don't treat tests, we treat people. So we have to always remember that. Now, the diagnosis has to be correct. If seizures are brought under control with a different treatment, they would not be considered refractory. Now, this is an important point here. Triggers and lifestyles have to be addressed. So among a lot of things that we use to treat epilepsy now, we sometimes forget about this. So if, let's say, you're sleep deprived, this can trigger certain seizures, actually types. So you want to be aware about that. And addressing the triggers is equally important. It's not just about taking a medicine or a pill. It's about doing what is right for you and your body. And part of this is identifying the triggers. So lights, strobes of lights, for example, can be a trigger for certain epilepsy syndromes. Sleep deprivation or not sleeping well or having irregular sleep pattern can precipitate that. So that's important to understand here. So what are the common reasons for uncontrolled seizures? You might have the right medicine but not the right dose. That's one reason. Polypharmacy, meaning that you are using a lot of medications together. That makes you at a high risk of side effects, and also it might not work. If you decided not to be compliant, meaning that you're not taking your medicines, that can be a big cause for not having control of the seizures. Things like illness, sleep deprivation, stress also can actually predispose to seizures indirectly. If you have an abnormal brain, some genetic causes. So if you basically, that's how your body is, so, and you have predisposition. And for our little girls here, the genes are the structures that governs the color of your eyes, the color of your skin, right? Good job. Okay. So epilepsy, epilepsy course, usually it can start any age. We usually see peaks in very young or very old, but it can happen in adolescents, early school age, seniors. 5% of the population, about 3 to 5% can have a single seizure. 0.5 to 1% have more than one seizure. And as I said, more than one seizure is what people refer to as epilepsy. Again, that's the big label. 70% of the epilepsy cases can be and are well controlled with medications, appropriately chosen medications. 30%, unfortunately, will be what we call intractable or pharmacoresistant. It is not being treated. So epilepsy versus epileptic syndrome. So epilepsy is not one disease, okay? We are speaking about that. We put everything together. We put the age, we put the description of the seizure, we put the findings on the EEG together. And what is important again and again, and I have just a case today in the clinic, the EEG is one thing, but when you put the EEG with the story that the people say, you come up sometimes with a different perspective that might change how you're going to approach that case. So that's important to understand. Now, when there is a cause in the brain, so someone have a trauma, like tumor, something in the brain, got an infection, this is referred to as symptomatic epilepsy. A lot of times we don't have a cause. And I tell people actually that when you don't have a cause, that's not a bad thing. Sometimes when you have something bad in your brain causing it, let's say you have a brain tumor, that's not a good thing. So it's better not to have a cause rather than having a bad cause. And epilepsy also occurs in children, and it's one of the peaks for age for kids to have seizures. So based on the nature of seizures, rather than the presence or absence of an underlying cause, we classify epilepsy. So in general, seizures are classified either they're coming from both sides of the brain or different parts within the brain for generalized, or coming from a certain focus in the brain. So if it's coming, let's say, from this particular part of the brain. So we have generalized, and then we have focal epilepsy types or seizure types. So here, focal seizures is about 80% of adult epilepsy. You will hear those terms. They're actually kind of old terms, but you will hear more still people talking about simple, complex, partial seizure, second generalized. And this here refers to just different kind of what we call focal seizures coming from one side of the brain. And it just refers to are you aware, not aware during them when you're having them. And here, so these are coming from one side. Here, if it starts from here and spread to both sides, and that's more of the generalized. And you'll hear about those terms here. I put them here, but I put a more layman terms here to understand what this refers to. So absence, you're just staring, okay? Myoclonic, you are just jerking briefly. Clonic seizures, you have prolonged jerks. Tonic seizures, you are just stiffening and rigid. And then atonic is when you are dropping. So those are the different types of seizures that we see, and we try to put together in the particular epilepsy syndrome as I was referring to. So here, focal seizures. So that's an example of focal seizure evolving to generalized. So it starts on one side and then it spreads to the rest of your brain. That's what this is saying. And you see here, so that's the EEG. I put it here just for people to know what. So what's an EEG? So EEG is just your brainwave, okay? And that's a picture of it. And here you see, I always tell patients, think about it as the smooth waves of the sea. When you see high tides, this is what we will hear as epileptiform discharges. That's how you think about it. So you see here how this is smooth, and then you start seeing those guys here. And it's focal because it starts here, and then it seems to be evolving or getting higher in the height and how fast it is. So that will be an example here of a focal seizure. Now, you might hear about something called Statusepilepticus. And what is Statusepilepticus? Basically, if you have a seizure more than 30 minutes, so basically a long seizure. And it can be life-threatening, and that can occur. Usually successful of treatment relies on understanding what the cause is and treating it. We give an emergency medicine that maybe a lot of people are familiar with. It's called Diastat, which is a medicine that is given for seizures more than 5 minutes, or technically 3 seizures in 1 hour. There's actually another medicine I use called Versed also that serves the same purpose and is given through the nose. So I have been using it for some of my patients. And some people like it, especially in adults, because they don't have to go through the suppository route. But the message is that if you have a seizure more than 5 minutes, you might run into higher potential of having this seizure destroying your brain. So people intervene and give this medicine in the hope that they are going to prevent this from evolving. It can occur with things like strokes in older age. So usually older people, the strokes are one of the most common, or maybe the most common identifiable cause for having seizures or even status. You can have it after head injury, alcohol, medications, metabolic disturbances, pregnancy. So alcohol is bad for you, okay? You know that. Good job. Okay. and you give medication through the veins. And you want to do it fast if you're in the hospital. So when you come to the ER and you're having seizures like that, if you don't have this medicine, those rescue medications we call them, people can give you medications either through the muscles or through the veins to stop them. Sometimes people are admitted to the ICU to have those seizures stopped. So it is a potentially serious situation. Now, this is important. Epilepsy mimics. So not everything in the world is epilepsy. If you have something going on, the basics is we have to listen to the story to decide what is this. The diagnosis doesn't end or start by doing tests. It starts by listening to you guys. And there are mimics, so if you are fainting. Now, I put this here, it's important to understand. You might faint, you might have what we call syncope, and you commonly will jerk. So 80–90% of the time, you faint and you jerk. And people say, oh, it's a seizure. And there are certain things we have to ask medically to differentiate if it was a seizure or it's just fainting that can be caused from other causes, maybe the heart, maybe just benign things. But that's important to understand because that's a very common case scenario where we have a lot of mimics. And this is one of the biggest mimic that people just say, oh, okay, I fainted, and someone say that jerk, and then people start saying you're having a seizure. So the story here is how we differentiate. You can have irregular heart rhythm. Some kinds of migraines or headaches can be associated with seizure. That's a very important cause, low blood sugar. So one of the things that the EMS will do when they go to your home is check your sugar, because if your sugar is low, they will give you some sugar to correct that, because this can be potentially fatal if it's not corrected right away. This medical condition called narcolepsy, it's a sleep disorder, and it can mimic actually also seizures. There's something called narcolepsy and cataplexy, which are seizure mimics also that we need to be aware about. Panic attacks, a lot of times people just panic, and they say, oh, it's a seizure. That's not a seizure. That's different. The description of the event and how it starts and ends will be different. And then what we call non-epileptic spells, which basically means it's not a seizure. Now, actually, I use the term spells rather than non-epileptic because this can be confusing. And basically, it means that it looks like a seizure. It's a seizure-like spell, but when you get the EEG running, the EEG is normal. Very few exceptions can cause that in the epilepsy world. So it's reliably will rule out most of the causes, not all of them, but most of the causes that can be called seizures. Ideally, if the events are happening frequent enough and we are not sure, we want to capture them. So we do the test to try to capture them and say for sure if it's a seizure or not a seizure. Now, so what are some of the investigations we might be hearing about? So we look for treatable cause, like for example, the low blood sugar. We look for that. And that more in acute sessions. Also, if you have an infection that need to be treated, or if you have, let's say, drug ingestion, you need to treat that or identify that. So we need to identify a cause, and if we find it, we treat it. Now, EEG, the EEG that I showed you, you will hear about, and you will go to your doctor, so someone will say, we need to do a sleep-deprived EEG, which basically refers that you wake up. You are torturing yourself a little bit. You wake up earlier in the morning, and the idea is that you sleep, because sleep triggers more seizures. So we are trying to capture that on this. What we call ambulatory EEG is something like a Holter monitor. People carry it for a day or two. Depending on the situation, we try to capture the spell. There is also video EEG monitoring, where we have a video camera, and some of our team members are here. They do a great job helping us with all of those. Imaging, some form of imaging is recommended. MRI usually versus a CAT scan. And I always tell people about this, CAT scan and MRIs. So MRI give us more details of the brain. CAT scan is like a quick shot picture of the brain. So if you have to choose something to do on an outpatient basis, you would do the MRI, not the CAT scan. CAT scan is more for acute setting, when you're trying to rule out bleed, when people are in the emergency room. And CAT scan also is associated with risk of radiation, significant risk of radiation. One CAT scan is like being exposed to 100 X-rays. So they're very risk business of getting one even CAT scan. It increases your risk of brain tumor, especially in young kids below age of 15. We try not to do them except if we really need them as much as possible. And here, so as you see, that's how the cap, the cap here, some electrodes, brain, and then you have those brain waves. That's what you are looking for on the EEG. And some examples here. So as you see here,
and this might be a little bit technical, but the odd numbers are left and the even are right. And you can see in this page here that those guys stand up here and here. Again, the idea that you have smooth waves and then you have this what you're going to hear about as epileptiform discharges. It just means that something stands from the background like this. And our job as neurologists is to pinpoint if it's coming from one side, both sides, and what does it mean in the context of the patient we are talking about and talking to. We have to look at the EEG. Again, we are diagnosing the patient, not the EEG. Now, few data here. There is about 3 million people, as we heard, drug-resistant epilepsy in about 870,000. We have medications without evaluation, about 810,000. EMU is the inpatient unit that people get admitted to try to capture the seizures and pinpoint what type it is. And then there are different modes we are going to touch briefly about. So VNS therapy, surgery, 4,000, 3,000 have surgery, 3,000 can use a diet, a form of a diet, something called ketogenic diet that some of us might have heard about. It's more for kids actually used, but it also can be used for adults if they're willing to. It's a form of a high-fat, low-carbohydrate protein diet, and it changed the chemicals in your blood basically to stop the seizure. It's very effective, and it really can be used for different kind of epilepsy syndromes, though it's more described to be successful in certain syndromes. So as you see, only 1 to 2% of patients receive treatment every year, actually, which is another problem. It's really a shame, but this is the data we have. And part of this might be lack of awareness. Part of this might be lack of referrals. Like sometimes the primary doctors can wait too long to refer patients. That can sometimes be an issue. But in general, we need to identify and treat more patients who might be living with this. Now, VNS is one of the things I just mentioned. And VNS refers to this thing here. It goes into your chest on the left side. It goes from here. It's a wiring, and it's attached to this nerve called vagus nerve. And it controls seizures in patients. It sends like electrical impulses on semi-regular basis that are thought to abort the seizure. And it's a procedure. You have to go through surgery to have this done. It is indicated in certain patients. It has been approved in 1997. It's usually patients 12 years or above, and who have what we call those partial or focal seizures, so coming from one side of the brain. But in reality, we use it for both, generalized and partial also. But that's the FDA indication I put here. But there is good data about its use for the generalized seizures. And usually, it's more indicated when people have what we call the drop attacks, so like they're falling to the floor. VNS therapy is the most established device. There is 85,000 patients treated. We have a lot of experience with it, 25 years. More than 1,000 peer-reviewed publication. We have, it has been assessed 3 times by the American Academy of Neurology. So it has a lot of evidence for it, this VNS option. We start thinking about those options once we fail those 2 medications I spoke about. 2 appropriately chosen medication for adequate time. Once we fail it, we start looking for those options, the VNS, the ketogenic diet. Now, RNS is another thing which is we are all very excited about. It's a new addition to the epilepsy world. It's a brain-responsive neurostimulation system. It's indicated for patients who are 18 or older who have failed 2 medications and have partial or the focal seizures, who are at risk for neurological or cognitive deficits, who are not candidate for resection. So resection refers to what we call, you guys might hear about epilepsy surgery. What this refers to that if you can pinpoint where your seizures are coming from in the brain, you simply take that part out. But it's a very complicated process. It involves a team of people who have to come together, surgeons, epileptologists, psychologists, because we have to decide, first we have to decide, is this really the part of the brain that the seizure is coming from? What will happen if we remove this part? So it's a very complicated process, and it's offered in big epilepsy centers where they have the team available, like all the people I mentioned. But that option is not there for people, because that's the first option you think about. If you fail medications, will surgery cure me? Because that's what the literature tells us. If you are a candidate for surgery, don't be scared. If you are in the right place with the right person, and they know what they're doing, it can give you the best chance. But if not, then you go for the other options we've been talking about. And the RNS is a very interesting option now we have, and it can be used for patients who have been treated or not treated with VNS, and it can be also used for patients who are treated or not treated with epilepsy surgery. But as I mentioned, if you are a candidate for surgery, that really is the best initial route to think about if you fail medications. So who will you be able to help tomorrow? So that's just for us some numbers here. By the time we return tomorrow to work, there will be 77 ER visits, 35 fractures and head trauma from seizures, 17 hospitalization, 51 deaths. Those are the statistics. So it does have a big impact on people's lives. Now treatment. So in refractory cases, surgery may be necessary. We target the seizure freedom and improvement in quality of life, and surgery has been proven and shown to do that. Now, I just put there some common drugs that you might guys hear about. Carbamazepine, this is the Tegretol, Depacod, Lamictal, Keppra, Topamax, Neurontin, Zonogram. You will hear those names from your neurologist or in your practice. So the basic rule is simple regimen. We try to start slow and increase slow. You add another medicine if necessary, if seizures continue. I usually tell my patients I'm not a big fan of medications. I usually am not. But sometimes when we have like more than one seizure, so the rule of thumb, by the way, that we don't treat first-time seizure. But if someone is having 2 seizures or more, the odds of having a third seizure is high, is about 60% to 70%, especially if they have abnormal EEG or abnormal brain imaging. So then we start thinking of medications if we are dealing with this case scenario. And that's the rule of thumb. So treatment goals, seizure-free, no side effects, ideally. So that's important. We don't want to cure a problem to create side effects. And sometimes also it's a balance between the side effects and the seizures. Depends on the situation. Drug-resistant epilepsy, you optimize long-term seizure control. You maximize quality of life. You minimize side effects. You want to adhere to the medicine. You decrease seizure severity and post-ictal period. So all of those are goals. So in summary, there are different terms may be used to describe drug-resistant epilepsy. Uncontrollable, intractable, refractory drug resistance, they all have the same meaning, okay? And diagnosis must be correct, and triggers and lifestyle factors might be addressed. Seizures can be focal or generalized, and then you have to be aware about seizure mimics, okay? Okay, thank you. By the way, I'm going back. I didn't actually. How can we return to the first slide? Yes. That's what? Oh yeah, sure. Yeah, because we don't want to provoke any seizures. Smart suggestion. Huh? The pink heads? Yeah, they look familiar. Hello? I know those ladies. So why are you wearing this cap?
I don't know.
Oh, okay. Who gave you the cap to wear?
Those are the hats we have that, mimic the brain. Anybody, they're coloring. We have a coloring book and those hats that the kids can make.
Yeah. So I didn't speak about this, but I just wanted to. So you guys are familiar with those pictures? Some of them, right? So who's this?
Danny Glover.
Good job. And then who's this? Who's this guy? Try not to use the thing. The first guy. Socrates. And who's the second guy? So St. Paul, actually. And then who's this? Good job. See, people are very, and who's this? This is Napoleon. And who's this? Good job. People know history very well. And who is this? Actually, I don't know who is this. But I know who's this. Huh? Lenin. And who's this? Huh? Who? Oh, so this actually is Sir Isaac Newton. And who is this? This is Tchaikovsky. Or Tchaikovsky, I guess. And then the guy beside him is? Yeah, good job. And then after that is actually Alfred Nobel. And after that? Yeah. And then, so all those people are common in what? They all have epilepsy. Yep. So I thought that was neat. So I just put this there. So we make them more famous, I guess. Okay, I'll leave this now. Any questions? No? Here, there is a question.
How do you determine how long someone would stay on a medication for the seizures? Let's say if they're one of the people who are having a hard time adjusting to medications where their seizures aren't stopping with a certain medication, you guys have to keep on giving them different medications. How do you determine how long they're going to stay on a certain drug?
So few things, we make a clinical decision based on first the side effects. If the person is having side effects, then that can be a factor that we might just want to switch to another medicine. Also, we balance the side effects of the medicine with the benefit of the medicine to the epilepsy type. And the rule of thumb, as I mentioned, is to try not to use too many medications together as much as possible and manage on case-by-case basis. In general, if someone is controlled on medicine, we don't try, the rule of thumb is after 2 years, we can try to take them off medication. That also depends on some factors like how their EEG looks, what their brain MRI shows, if they have any cause. So for example, if they have a structural problem in the brain, let's say a stroke or a tumor, you might just keep them on the meds. So it depends on a number of things.
Are clustered seizures considered status as well? By cluster, I mean a couple, 30 seconds and then 5 minutes free time, then 30 seconds, and then...
Yep.
Is
Yeah.
that considered status?
Yeah, that's a very good question. And by definition, so the strict definition, it is not, but there is some debate in the literature about that answer. But in general, if you have seizures back to back, and if you're not returning to baseline, then by definition you have status. But if you're returning to baseline and you have, let's say, a seizure, and then you are normal for a few hours, and then you have another seizure, then that's not status. But if you have them back to back, yes. And that's why you have to give this emergency medicine, the Diastat or the Versed I mentioned, because you don't want this to continue.
Suppose that within your family you have several members that are epileptic. You have a family member who doesn't have it. You know that you have a kid who's after being born. Is it possible that that child doesn't have it? That child will end up not being epileptic?
Sure, sure. It is.
What are the odds?
So first of all, it depends again on what epileptic syndrome. So some epileptic syndromes have genetic basis for them. That's why it goes back to what I was mentioning about the diagnosis. So some of those epilepsy syndromes can have genetic basis and increase the odds of that baby having the seizures or the epilepsy syndromes, while others are not. So it really depends on the diagnosis and what epilepsy type you are dealing with to pinpoint if there is a risk or no. But in general, there is a risk with certain types more than others. And the best thing I tell people is to not worry about it too much. If you'll have a seizure, you will find out. Okay, so why worry twice? Basically. It won't change anything. But the best answer I can give you to pinpoint is it depends on the epilepsy syndrome type.
When you're trying a new medicine, okay, there might be a period in which things are going good, okay? does the brain then say, hey, I've had enough of this, I'm going to go back to my old self and get back to, is there like a honeymoon period with new medicines that they may only work for a short period of time?
Yeah, there is. There is a honeymoon period, but that's why we don't want to make any rushy decisions. That's why we wait for those 2-year time frames. So when we look at the literature, they try to answer for how long to treat, when to change. They found that if you do it too early, you have a higher risk of having your seizures coming back. And it's all a matter of risk. There is nothing absolute here. So if you stop the medicine, let's say after 6 months, because you're not having seizures, your risk of having seizures at this point is high. But after 2 years, if you remain to be seizure-free, and again, it depends on what your EEG and MRI, what your epilepsy syndrome is, then you have a better chance, or a very good chance, 70% or more of remaining seizure-free. So again, it goes back to the same idea of finding what kind of epilepsy. Now in adults, usually it is focal epilepsy, it's what we call temporal lobe seizures, where it's coming from the sides of the brain. Usually that's the most common in adults, but in kids it can be more diverse. So it really depends on what are you treating. But I would advise, if you're doing well on the medicine, stick with the medicine at least for 2 years before starting to think of getting off the medicine. That's the rule of thumb in general. And also there are other factors to consider. So in adults we drive. Sometimes people just don't want to stop the medicine because even if they're doing very well, they might lose their license potentially if they have a seizure. So there are a number of social factors here. And it also depends. Are you doing well? Are you having side effects or no? That can be also a factor to help with this decision. So it is something we want to talk with people about. And it goes back to what I said. We treat people. So a decision has to be explained. And what I like people always to do is to speak with doctors, and doctors speak back to patients about pros and cons of doing anything. So here where we are, here's the pros of doing this and stopping the medicine, this is what the data show us. And I usually try to involve my patients in the decisions as much as I can, because they are smart people also. And as I said earlier, we learn from them also. So it should be the decision that you want to discuss all aspects of with your doctor to make the right decision.
When you say seizure-free for 2 years, do you mean just major seizures, or are you talking like maybe little 10 or 15-second seizures? Do they count in your 2-year time?
They count. Any seizure count. So our goal should be seizure freedom, and seizure freedom is anything. And again, I cannot stress, it really depends again on what kind of seizures you are being treated for. To understand that. People really need to understand what kind of syndrome fits into their epilepsy type, so that they can understand the implication of this. Because sometimes this is going to help you in understanding what is your chance of being treated or being controlled, for how long you need to be on the medicine, and when to stop the medicine. It is a multifactorial decision that involves a number of things here. But yes, our goal should be seizure-free, because sometimes also you might have those mini ones, and then you start having the bigger one. You cannot know what will happen. So yes, you want to cure seizures and eliminate seizures, period.
So in the scenario where the length of the duration of medication exceeds 2 years, perhaps even goes past a decade, given that number of medications were introduced in the last 20 years, has there been any study or evidence of what the long-term impact of being on some of these medications is or is not?
Yeah, there is. And see, medicines are good and bad. Like anything, there are side effects. And that's why we try to not use too many of them, and hopefully not use them for a long time. And there are older medications that I had some names there, like Depakote, for example, and there are newer medications. So the data is more there for the older medications more than the newer medication, but there is also some good data for some of the new medications. In general, seizure medications can affect, on the long run in particular, so it depends on the medicine. Like for example, Topamax can affect your concentration, your thinking. And this can be also dose dependent. So that's something else. The higher the dose, the more the chance of side effects. So that's something also we want to be aware about, how much of the medicine we are taking. A small dose is not similar to a bigger or a larger dose. So the type of the medicine, for the dose of the medicine, also medication interaction can affect this. So if you are using a medicine like Depakote and Topamax, it's not the same, or Depakote and Lamictal, for example, which are known to interact notoriously with each other, is different from using, for example, Keppra. It's another common medication we might hear about. It begins to be maybe less side effects with Keppra. But none is side effect free. All of them can have side effects. And now each medicine have a more well-known side effect. Like, for example, Keppra, usually the most common side effect we worry about is behavior. Depakote can affect hormonal changes. Lamictal, you can have GI issues. So it depends on the medicine that you are using that you have to worry about a particular side effects. And by the way, seizure medication can cause seizures also. That's an important point. So to understand, we have to keep this in mind. Yes?
I was on a whole bunch of different medications I was allergic to. And finally, my doctor put me on Dilantin, which is a very old medication. The side effects for that?
Short-term or long-term, you can have side effects. It can technically affect your liver sometimes. It can affect your gums sometimes. It can affect your brain architecture sometimes. You also can have, sometimes if you have acute toxicity, it can affect your eyes. You can be unsteady, for example, abruptly if you take too much of it. But see, the thing is, it's always a balance between the side effects potentials. If this is the only medicine working, it's not a bad medicine necessarily. And we do use it more in adults than peds, actually. So it's not a bad medicine, but if this was working for you, this was working for you.
If you were on, like, starting out, you started out with 500 of Keppra once a day, and then you started experiencing more seizures, and then they put you to 750 once a day, and then 750 twice a day. And with the lower doses, I found that there was less seizures, and now it's 3,000, and you're having more seizures frequently. So you're saying that the medication can cause more seizures?
Potentially, but doesn't mean it's causing the seizure. It's just something to figure out here in the mix. But what we worry about more in those situations is we have to reach a dose of the medicine that we know is effective. Because when you start at a small dose, the medicine might not be doing anything at all. So you have to start slow, increase it slow, and give it some time. Because we don't want also to rush into conclusion based on observations. So having increased seizure at the start might be just part of the epilepsy syndrome rather than from the medicine. But in general, medications can cause that, can cause seizures, but it's not the first thing to think about. It's more or less on the rare end, but it can happen. But we think more about the side effects in terms of the medicine itself, and again, the epilepsy syndrome you are treating. If you are choosing the right medicine, what you want to worry about first if it's the right medicine. Give it time, increase it slowly, watch for side effects, and then go from there.
What's the highest dosage of Keppra you can take?
Okay, I can give 4, 6, 5, 6 grams. I have given large doses. Keppra tends to be a safer medicine. The issue is this. The issue is that after a certain dose, the chance of the medicine working drops. So it's a safe medicine, but usually around 3 to 4 grams, something in this neighborhood. After that, if you use higher doses, it might be safe, or one of the safest relative to other medication, but the efficacy of it might not be as good at the higher doses. Sometimes people just use another medicine. Again, it goes back to what I'm saying. What are you treating? You need to understand what is the kind of seizure you're being treated for. You had a question? Okay.
I just feel compelled to share one long-term issue that we're dealing with after 20 years on anti-epileptic meds is issues with bone density. So someone who had the question about long-term drug usage, there are important things to learn about, which we kind of missed that for a while, and we're now trying to catch up.
So that's an important point, and there is actually certain epilepsy medications are notoriously known for the bone density problem, like Depakote. Dilantin actually can be one of them. Tegretol is another one. Phenobarb. And those certain medications are notoriously known for that. Not all of them, though. And that's why we can supplement with vitamin D. Sometimes people do bone tests to monitor your bones while you're on those particular medications. So it's something to watch for when you are on those particular medications. Any other questions?